Before I call next presenter, I would request Dr. Abdul Bari and Dr. Mohammad Hashim Badaich to come on the stage and grace the chairs, please. Second presenter is Dr. Farhan Memon from NICVD, and the title is Reverse Order PTMC after Tricuspid Valve Replacement. My humble request to all presenters, please finish within time.
Thank you, Dr. Hashim. Bismillahirrahmanirrahim. I am Dr. Farhan from the NICVD, going to present the case of reverse order. So I don't have any potential conflict of interest to declare. Our patient was 60 years old male who was ex-smoker with a history of the tricuspid valve replacement in 1997 when he was at the age of 36. And the only record that we have, his valve was replaced because of the tricuspid regurgitation. And he has been presented at the ER with the complaint of shortness of breath, function class 3 to 4 since 2 to 3 days. So after stabilization, when the echo was done, it revealed the mitral valve area of 1.2 by the planimetry and 1.3 by the pressure half time, and the gradient was 11. Mean gradient was 11 mm. And there was normal functioning prosthetic valve at the tricuspid position. That was a ball and cage valve with the mean gradient of 3 millimeter of mercury. And the T was done, sorry. That was the T. It was revealing the area of 1.2 with the gradient of 11 mm of mercury with the mild MR. And there was normal functioning tricuspid valve at the tricuspid position with the mean gradient of 3 millimeter of mercury. So what are the other options in order to treat that patient? Anyone from the audience? We have already tricuspid valve, mechanical tricuspid valve at the tricuspid position that was normal functioning, and the patient INR was also in therapeutic range. So it was decided to take that patient for the PTMC, and on the table left heart cath was done, which revealed the moderate disease in the OM. So the procedure for the PTMC was started, and the LV-EDP as well as LV angiogram for done in order to confirm the MR that was also mild. So how we have taken the RV pressure in that case? Anyone from the audience?
RV pressures. How you will take RV pressures?
Yeah.
Echo one method is to find the RV speed through PR and
No. During the PTMC, we took
Okay,
the
okay,
RV pressure.
okay.
So how we have taken the RV pressure in that case? We skip that step, and we started with the LVDP and started the procedure. So in that case, we didn't take the RV pressure because the tricuspid valve is there and the INR was in subtherapeutic range. If we touch the tricuspid valve, it might lead to the thrombotic complications. So it is the puncture needle at the septal position that was confirmed by 3 different views at left lateral, AP and RA view in order to correct puncturing of the septum, because we have the tricuspid valve. So we punctured the septum and we passed the PTMC wire in the LA, and Mullin sheath was forwarded. Finally, the balloon was inflated. And that balloon was 26 size. This was the whole procedure. There is no any moderate MR.
Sorry, what was your approach?
Femoral,
Both femoral?
right femoral.
ठीक है.
We took the so many steps before puncturing of the septum because of tricuspid valve. So we entered in the LA and PTMC wire passed, and finally the balloon was inflated. That was the second inflation. And the echo was done that revealed the area of 1.6 by planimetry, and the gradient was less than 5, mean gradient. So usually the TR developed after the MS, but in that case, the TR developed before the MS. So always consider the rarities before labeling the someone with the mechanical valve with the thrombotic complications. Always consider the rarities before labeling the someone who presented at the ER with the dyspnea or any other symptoms.
इसमें मैं कहना चाहूँगा इसकी सर्जरी क्यों नहीं करवाई ऑलरेडी ट्राइकस वेल्व रिप्लेस में MVR करवा देते.
Patient was 60 years old and already the patient has a surgery, and redo surgery in that cases is very high risk. So always use the low risk option rather than considering the high risk option in that cases.
एंटीकोगुलेशन का भी इशू, उसमें INR का थेरापेटिक क्या रखेंगे अगर ट्राइकस्पिड वेल्व और माइटल वेल्व रिप्लेसमेंट हो? बहुत मुश्किल है.
This is not an issue of maintaining the INR because the patient was already taking the warfarin, but it was the risk of the surgery that we have entertained before taking that patient for the PTMC. Patient was 60 years old male who has already has a surgery, and if we took that patient for the redo, that might be high risk.
Any comments from panels?
Just for our interest, I'm asking, what was the past history of why she had tricuspid regurgitation? What was the etiology of that, and how many years back she had surgery, and why they went for prosthetic, where usually prosthetic valve at tricuspid area is always avoided in most of the cases. आपने 97 में कहा है probably NICVD
Yeah.
में हुआ होगा.
नहीं नहीं, probably NICVD में नहीं हुआ था. It
अच्छा,
was
okay,
done at somewhere
then I
else.
can understand.
Yeah,
Okay.
yeah.
At that time हमें ball and cage वालों से हम निकल चुके थे. तो
Yeah.
I was just wondering why this patient had ball and cage. तो आपको क्या लगता है उसकी उस वक्त tricuspid की etiology क्या थी, tricuspid regurgitation की?
It was some thought
You
of the
should have
primary.
looked into that because at that time mitral valve must have been normal at that time, right?
Oh, yeah.
This is
Yeah.
on my interest.
मोस्ट प्रोबेबली इन्फेक्टिव एंडोकार्डाइटिस जो इनको आईवी ड्रग अब्यूजर को होता है मोस्ट प्रोबेबली.
But his DC card doesn't show any of that record. The
Why not other options of tricuspid valve replacement were taken on board? Like bioprosthetic tricuspid valve replacement rather than any mechanical valve because it's low pressure chambers RA and RV and then it may causing a higher thrombogenicity in those cases.
sorry, I couldn't got your question.
क्या क्वेश्चन क्या था डॉक्टर जावेद?
उस वक्त tricuspid valve replacement bioprosthetic क्यों नहीं लगाया गया था या Ross procedure क्यों नहीं किया गया था?
Done at the age of 25 when he was very young.
ये
Yeah.
बता रहे हैं कि ये ओल्ड केसे कहीं बाहर से हुआ था आउट ऑफ NICVD, तो रिकॉर्ड नहीं है इसका प्रॉपर.
Okay.
Just he has the record of the tricuspid valve was replaced because of the TR.
What was new thing in your point of view to represent this case over here? Like you were telling us, it's actually reverse loop order. So what was the most compelling indication for taking this reverse loop or disorder? आपने reverse loop जो order बनाया था इसका PTMC करने के लिए उसको क्यों बनाया
no.
था? कोई खास वजह थी उसकी?
We didn't do the
Because you are not going to touch the
That was not
tricuspid
the-
valve and you are going to from a venous system to by interatrial septal puncture and then you are going into a LA and then going to PTMC.
नहीं, tricuspid valve तो क्रॉस नहीं करा ना.
नहीं नहीं, we
तो
didn't
वही
cross
कह
the
रहा हूँ ना,
cross
tricuspid
नहीं
valve
करा.
because we entered from the IVC into the RA.
Yes.
And we didn't go into the RV because of the tricuspid valve, so we couldn't able to take the RV pressure. हम तो
Okay.
गए नहीं ना
हाँ
वहाँ
वो तो अब
Regarding this right ventricular pressure, if you have difficulty in doing that by Doppler, there are other ways to do that. You
Yeah.
have to take the right ventricular outflow tract TVI,
Yeah.
and then you can calculate mean pulmonary artery pressure from that. That one can do that very routinely.
थैंक यू वेरी मच, नाइस डिस्कशन.
You can take
Thank you, Dr.
these
Farhan.
pressures from echo as well.
I would call Dr. Wasim Sajjad from Lady Reading Hospital to present his case. And title is Out of Frying Pan into the Fire. Very thrilling. Let's see what's inside.